Hello, and welcome to the webinar for Final Rule for MIPS 2022, What You Need to Know Now, presented by Christy Brantley and Heather Miller. We're on the Professional Services Consultant team, and we are MIPS consultants here at NextTech. So, top things that we're going to discuss today. One is the MIPS Final Rule for 2022. We're going to do a little breakdown of the cost category, since that is going to affect more specialties in 2022. We're going to do a breakdown of common worries and themes for MIPS, and then we'll have a live Q&A after the webinar with myself and Heather to answer any questions that you have. Also, remember, the on-demand recording will go out to all registered attendees. That will go out on Friday due to tomorrow being a holiday. It will be the on-demand recording. The presentation itself will not go out, but it will be a recording of the webinar. So let's dive in. Nitty-gritty stuff here. Lots of changes for 2022. So MIPS changes for 2022. So first, we'll start with the threshold to avoid a negative payment adjustment is going to be 75 points to avoid the negative payment adjustment. That was the mean average score in 2017. So that is why we are at 75 points due to the mandate for 2022. As you can see, we have increased quite a bit from 2020, 45, 60, and now 75 to avoid the negative payment adjustment. Also, the exceptional performer bonus threshold has gone from 85 to 89, which the exceptional performer bonus is very important when it comes to MIPS. We have category weights. So you can see the category weights for 2022, 30% for quality, 30% for cost. Promoting interoperability is still at 25%, and improvement activities is at 15%. Final score calculation. So we still have the 2022 final scoring of a positive payment adjustment of 9% and a negative payment adjustment of 9%. But as we all know, we could result in less than a 9% adjustment in positive payment adjustment, as we have seen over many years.
All right, I'm going to actually jump in for Christy. I think she's having grabbing some water and getting a little choke. So, and I think actually she's losing connection. So this is Heather. I'm going to jump in and take over here for the updated final changes for the quality measure category. So the quality category is still going to remain at a 12-month reporting period. You will have to report your top 6 quality measures with a data completeness of 70%. This is both for 2022 and 2023. It was in the proposed rule that they were going to increase the data completeness in 2023 to 80%, and that actually did not pass, and it will it'll stay at the 70% that it's been currently and moving forward. Also in the final rule, there was the final removal of 13 quality measures. There were a few that were proposed to be removed, but are no longer going to be removed. We still have substantive changes to about 87 of the existing MIPS quality measures. So even though a measure technically is not new or has been removed, you always want to make sure you go look at any other basic changes or small changes that could have occurred to some of the MIPS measures that you might be reporting for the quality category. We do have an addition of 5 new quality measures that were finalized, and they also continued to extend the CMS web interface for those that report in group, virtual, or ACOs. For the final changes in quality, the 5 new quality measures, again, not very much related to the next tech specialties, but these are 3 of our normal CMS, and then we have 2 administrative claims measures that have been added for the 2022 reporting year. And then more of the impact here is going to come to those that were proposed to be removed, and then the final 15 that actually were removed. So the good news for our ophthalmology groups is the age-related macular degeneration, our AMD measure, was only removed for Medicare Part B claims type reporting. So good news for those that utilize the registry to report this measure would still be something. Now it is a topped-out measure, so we're only looking at 7 points, but definitely something that could be considered in your quality list. Diabetic retinopathy, the communication with the physician managing their own ongoing diabetes care. This measure did not get approved for removal. So this will still be something to be considered, is a 10-point measure as of this year. Obviously, we want to check it out for next year to confirm. For our dermatology groups, again, some more good news. The melanoma continuity of care measure for recall system did not get approved for removal. So this will be something you can still submit for your quality reporting. And same with 317, which is the preventative care screening for high blood pressure, also not removed as it was proposed. The one that did get removed per the proposal is our number 337 psoriasis and tuberculosis measure, which was actually slotted for last year, and it hung on for another year. This year, it did move on in and no longer is going to be able to report it. And then there's other ancillary ones here, not as much relevant, but just something to pay attention to. If you happen to report on any of these would no longer be options in the 2022 reporting period. So as measure scoring, so as we know in the quality category, we have a benchmark that we will work towards if they have benchmarks. They've established a couple different ways that this scoring will work, and any new quality measure, obviously benchmarks are historical, and so if it's a new measure, we don't technically have historical data yet. So they've approved a final version that we would receive 7 points for the first year of a new quality measure, and then down to 5-point floor for the second measure. So this is just assistance in the idea that these don't have benchmarks yet, so they give you a little bit of a push there. Also, for proposed rule, this was supposed to be just 5 points for both years, and they ended up increasing the first year to 7 and giving the second year 5. Moving on to measures with a benchmark. So there's a 3-point floor that we've been working with since the first year of MIPS. This 3-point floor is being removed for both small and large practices. So the measures will receive 1 to 10 points. So in the past, if we were reporting a measure, the lowest we could get on that measure was going to be 3 points. That has now been changed, and in the final rule, we will see that floor go down to the original 1 point up to 10 points for max. Now, measures that do not have benchmarks, there also will be the removal of the 3-point floor. These measures would be worth 0 points, and that would be with the exception of small practices who would continue to receive the 3 points. Measures that don't meet case minimum, which is the 20 qualifying patients in the denominator. Also, we have the removal of the 3-point floor. It will be worth 0 points, except for the exclusion of small practices, who then would continue to receive 3 points. So those are some big changes in how many points you could achieve in the baseline of that floor score for measures with and without benchmarks. Now, the good news out of the final rule, one of the proposed ideas was that we might not have good historical data to run our benchmarks off of. and they do feel that they've had solid data to be able to establish a clinical year 2020. So we will see benchmarking, which will allow us to utilize them and manage our scores through the reporting year. Christy, I know you're back. Do you want to jump in, or do you want me to keep going?
Absolutely. So MIPS 2022 final changes for the bonus points. This is a big one. We want to pay attention to this section. High priority bonus points would not apply for measures beyond the one required. So now if we submit outcome measures or high priority measures and we submit multiple of them, we get an additional bonus point for each one that we get after the first. So on that, you will no longer get that. So you will submit one, and if you submit multiples, you don't get any additional bonus points after that. End-to-end bonus points would not apply to measures reported electronically. So we were getting 6 bonus points for end-to-end. That will no longer happen. So those bonus points have been taken away. So those 6 bonus points no longer applicable. Small practice bonus and improvement score bonuses will both still apply in the calendar year for 2022. So meaning small practice, 15 providers or fewer, is going to receive 6 bonus points. And then if you have an improvement score on a quality measure from year to year, you're going to still receive bonus points for those in 2022. The complex patient bonus is double points, capped at 10. That will be added to the final score. So let's talk about MIPS 2022 final changes for promoting interoperability. This is still a 90-day reporting period, any 90 days that you would want to report on. One of the changes for this category is an automatic reweighting for small practices, meaning that your reweight is going to go into your quality and your improvement activity score. It is automatic, so now you have to go out to QPP, you have to apply for it if you want to take that, if you want to reweight that category. It is an automatic reweight. Remember, if you do a test or you choose that you want to test for PI, you can. It will trump that automatic reweighting. Also, with everything that's going on with the changes of MIPS, just be sure that that quality score is where you're going to want it to be if you choose to not trump the reweight. Prescription drug monitoring program measures is still 10 bonus points. They modified the patient access measure to require that all patients have access to their health information for all encounters on and after January 1st of 2016. And then add it, so not only do we have to do the SRA, security risk analysis, there's a new measure that you're going to have to select yes or no to an annual assessment of the high priority guide of the safety assurance factors for EHR resilience guides. It's called SAFER guides. So that's going to be something on top of the SRA. And then modified statements and information blocking attestation. And then we have required reporting for your registries, unless you can take an exclusion that can be claimed. Also on that, if you report 2 registry reportings and then you report a third, you get 5 bonus points for the third. But if you report 4, you don't get 5 bonus points for 3 and 5 for 4. So it's going to be 5 for the additional one, and that's it. So this is just a little slide on SAFER Guide, since this is new and it is a yes or no at attestation in 2022. There is a website link here that's going to take you to the SAFER Guides. The SAFER Guides consist of 9 guides organized into 3 broad groups. These groups enable healthcare organizations to address EHR safety in a variety of areas. So go out to the site, look at the SAFER Guides. This is something that you will need to do on top of the SRA. Improvement activities. It is still a 90-day reporting period. You're going to need, of course, one high or two medium for a small practice, or 2 high or 4 medium for a large practice. There is an addition of 7 new improvement activities that focus on health equity. And then there is a removal of 6 improvement activities, which we have listed. One that I'll mention is regularly assess the patient experience of care through surveys. That is an improvement activity that is used quite a bit. So just make sure if that is something that you are using, or if you're using of any of the removed improvement activities, that you go out to the site and look for other improvement activities. Also, there is a modification to 15 current improvement activities. So very important that you are going out there in 2022, reviewing your improvement activities that you're using, and make sure there hasn't been any modifications on those. Remember, with your improvement activities, 50% of your providers need to be using the improvement activity to be able to attest for the improvement activity. One of the big changes for 2022 is the cost category. The cost category has 5 new episode-based measures for 2022, 2 procedural measures, 1 that will affect dermatology and plastic surgery, which is the melanoma resection, 10 episode case minimum. And then we have the diabetes that could affect ophthalmology with the 20 episode case minimum. Since cost is being thrown into the picture for 2022, we are going to do a cost category breakdown. So just dive a little bit deeper into the cost and what actually is going to trigger for these measures to get you into that cost category. I'm going to have Heather take over. She's going to go over the cost category, and we're going to break down some of those measures a little bit deeper.
Awesome. Thanks, Christy. So cost category breakdown, and as Christy is outlining from the very beginning, is cost is becoming a big portion of the MIPS score in 2022. We're going to see it move to an equivalent to quality at 30%. This is by mandate. There was nothing much we could do. We knew this change was coming. And so we want to make sure that everybody has as much education as they can on this category. It is probably one of the more complex and also one of the most unknown per se, and how you can manage it prior to the end of the reporting year. So I'm going to kind of break down the different cost measures that are impacting the next tech specialties. We've got our ophthalmologists that have already been impacted in previous years to the routine cataract removal procedural measure. And then they've had the addition of the chronic care diabetes. And I'll walk you through some of how potentially this could affect some of our ophthalmologists. The orthopedic groups, the elective primary hip and knee. Again, knee has been around, and then the hip has been added in the 2021 year. And then as Christy outlined, we've got the new melanoma resection episode measure being proposed and then finalized for the release in 2022. So the biggest thing about cost is understanding it. These are claims-based measures, meaning there is no report that we run like we do for quality, like we do for PI, where we get a numerator denominator. This is specifically off of a claims code list that is being submitted to Medicare, and it is basically setting up your average cost to Medicare for these specific procedures, or again, if it's in the chronic care side, the management of something like diabetes. There is a web link here to a CMS website that does give the code list files that I'm going to kind of be showing you. And I would highly recommend grabbing these files and really beginning to understand exactly what would qualify your practice, because the caseloads, as you heard, are 10 for our cataract, hip, knee, melanomas, and then 20, I think, for the diabetes. So there's not many needed eligible episodes to make you be included in this. So in most cases, this is going to impact the majority of our next tech practices. So let's take a look at what these code list files look like. So this is an example, and when you go to that web link, you will be able to go to a zipped file, and it will provide you with a Excel worksheet. This is the example of our cataract removal. The cataract removal is a trigger or a procedural trigger cost code, meaning we have a trigger that defines the episode. Then we're going to have an episode window, and in the case of the cataract, it pre-triggers 60 days before the trigger episode, and then 90 days after. It's then going to apply or attribute associated costs that are related to that surgery and do a 150-day cost average to Medicare. So these sub-tabs, this is kind of the definition of what you're going to find in each of these tabs, will allow you to dig in and understand exactly what those attributes are, what are the possible services that can get assigned, what and what could be excluded. So I highly recommend grabbing these and making sure you understand exactly how this measure works and what the coding that is going to be involved to get you into the measures. So when we look at the cataract trigger, we're looking at one CPT code, very basic 66984. It is the removal of a cataract. Now, it is not a complex cataract surgery. You'll notice if you bill that code, it technically is not the trigger for this measure. So CMS does do the best they can in making sure we're comparing apples to apples. So we don't want complex surgeries compared to regular surgeries or just a typical cataract removal. Also, in some of the exclusions are going to be some of your chronic conditions. So if somebody has glaucoma or other conditions, they also do get removed. They also throw in some risk factors for different associated costs by zip code. All of those things are already worked out in the overall algorithm so that when your average is created, it is very much already been averaged out to match your peers so that we're all being compared to an equivalent line. So this is the example of routine cataract removal. Again, we have one CPT code, and then we've got that 150 day range. When we look at the cost category for knee and hip, they are also procedural cost measures, meaning this CPT code will trigger it. They also have a trigger time frame or a measure 60 days before, 90 days after, that would do exactly the same that the cataract does when these are billed. And then we've got the new measure this year for melanoma. So melanoma is a bit unique in that it not only requires that we have a CPT code, we also need to have a matching or a diagnosis code of C43 or D03. So it is also a trigger cost episode measure, but not only is it CPT, it's the CPT with a diagnosis that's listed here. So if you're billing these incision or closure CPT codes and your patient has this diagnosis of melanoma, that would be considered a trigger and you would get pulled into the measure. The measure then would look at the trigger period and then again associated your average cost to your cost score. Now, the difference between the diabetes is this is a chronic condition measure. Different than a procedural or trigger measure, this is actually looking at care over time. So it looks for 2 claims that are billed within 180 days by the same provider. And in the instance of the diabetic measure, this is the list of the CPT codes or the E&M codes that they are stating if you bill 2 codes from here within a 180-day period and associate it with a chronic diabetic diagnosis, you could get pulled into this measure. In regards to our ophthalmologist, I know that a lot of you bill the average or the normal office visit codes for your new visits, and then potentially your comprehensive eye codes for your second visit, which would keep you out of this measure or being considered for it. As you'll notice in the CPT code list, I put it on 2 slides here because it's a little longer. Those actually are not there. But if you are billing standard established office visits and new patient office visits for your eye appointments, potentially you could have 2 claims within 180 days and be considered into this measure. So just something, again, as to why it's very important that you guys are understanding the codes that are going to get you eligible, and then make sure you're coding correctly in your office so that you don't get pulled into things that maybe aren't going to be relevant, and again, are going to be 30% of your total MIPS score. So the education of this is pertinent, and I think what needs to be on everybody's radar. Now, the big question is, how do I know what my score is going to be? This is the hard part, because cost category is claims-based. We typically don't get our cost scores till after the end of the attestation year, 6 months into the next year when they release our preliminary scores. The only groups that have access right now to, let's say, previous year data are going to be our ophthalmologists for the cataract and then our orthopedics for the knee. Both of those episode-based measures for cost were scored in 2019. You can go access your data files at the QPP portal in your performance feedback reports. You'll drill into the cost category. You'll see that you can see cost details. You'll then go down into that actual episode measure, and you can actually produce an Excel file that'll show you that episode and then all of the costs that were associated in that 150-day range and how CMS is, again, scoring you for this measure. So once you've got your data, if you receive 10 eligible episodes, that would push you into being scored. So once we're scored, we take the average of our peers on a live current year benchmark. So the hard part is this is our benchmark for cataract in 2019. So in 2019, 5,082 was the high end of somebody that was eligible for this measure, and they set the high mark. Somebody else set the low mark at 2,840. That benchmark is then the established range, and wherever your practice or individual doctor falls is where you would get assigned your MIPS points. So in this example, this practice average was 2,850, so they received 9.88 out of 10 points because their costs were closer to. Now, if I'm down on this end, obviously I'm going to be in the 1-2 point range, and so on. So by accessing current year data, or past year data, sorry, you would be able to somewhat be able to project where you fell in 2019. If your practice and scope hasn't changed too much, you could assume you'd be in a similar situation. So you know this one is actually, obviously they're in a really good spot. I would still study the code list. I would still make sure you're coding your cataract surgeries correctly, just so that you're prepared for future years, because this is a moving target. Next hard part was 2020. COVID came and CMS deemed the cost category as not having valid data for them to score anyone against in the cost category. So they reweighted the whole thing, and they did not provide us any type of data files where we could have done this with 2020 data. We don't have it. So all we really have is the education of the measure, how it works, past year data, if it again applies, and trying to kind of get a good understanding of your current billing situation, and assuming you're following those code lists. So I know that's a lot. There's a lot of layers to it, but it is so important to just understand it. Make sure your providers are aware of it. Make sure, because it's 30% of the score, and it's, again, the one thing we really don't have too much control over. So I'm going to let Christy jump in, and we're going to kind of tag team this common worries and themes, hopefully being able to answer some of your basic questions and be able to get to our Q&A and kind of follow up on anything we don't get.
Exactly. Thank you, Heather. Wonderful news on the cost category. Thank you for that information. I just want to state we are going to do a Q&A after this section of the webinar, so I want to make sure that you are logging. You can go ahead and log your questions, and then we can get to them as soon as we complete the common worries and themes, and that will give us hopefully a little bit more time to answer everyone's questions. So common worries and themes, big here, and it's going to be big because of 2022 and the changes. As you notice, 2019, 2020, and 2021 was kind of stagnant, just, stayed a little bit the same. We didn't see a whole lot of changes. 2022, we're seeing a lot of changes. So with that, that means staying on top of your MIPS is going to be very, very important. So how do I stay on top of the changes within the QPP program? So sign up to receive the CMS email updates. That is very important so that you can see when the final rule comes out. You can see when certain updates come out. It's very important that you're signed up for that so you can get those alerts. Also, do what you're doing now. Attend training webinars regarding MIPS and regulatory topics. So if a webinar comes out, make sure you're staying on top of those so that you can get the most updated information. There is times when things have changed, unfortunately, in the middle of a year. So, and I will mention the flu measure. We had a benchmark at the beginning of the year of 2021, and then it went away at the end of March, beginning of April. So things like that, you just want to stay on top of. Confirm your subscription for NextTech Compliance Corner. I know there's a lot of people who don't actually get that. So if you are a customer with NextTech, make sure that you're set up to get that compliance corner, and make sure there's multiple people within your office that are set up. And then, of course, you can ask for help and hire a MIPS expert. That is what Heather and I do. And we can get all the information for you. Make sure you're staying up on top of all the updates that you need to know.
All right.
So how do I strategize for MIPS 2022? This we wanted to really, really focus on due to the changes, due to needing to have the 75 points, and with the cost category being so important in 2022, we want to make sure that you do not wait until the end of the year to focus on MIPS. That will not work in your 2022 reporting year. It is going to be very important to start monitoring your MIPS month to month, strategize at the beginning of the year, pick measures, decide what you're going to do, decide what your strategy is going to be. If you get to October, November, December, it's going to be very hard to meet that 75 point threshold to avoid that 9% penalty. So start monitoring your MIPS, monitor it month to month. Again, like I said, with the changes in 2022, you'll need to make sure your score is as high as possible to avoid the 9% penalty. We're losing the bonus points, so remember that. The only additional bonus points that you will get is going to be that 6 bonus points for small practice. So if you are a large practice, you're losing quite a bit here. Small practices are also, but just kind of think about that. And then, as Heather mentioned in our previous section about cost, the cost logic, understand it, know what triggers you into cost, how it's going to affect you, and make sure that if you just know where you're going to be on that cost. It's going to be difficult because, again, like Heather was saying, we don't really have any historical data for derms or plastics, so we're not going to be able to kind of see where the benchmark is. And it's a constantly moving benchmark because it's due to your peers and it's claim-based, so we will not know those benchmarks until around June of 2023. So just know the cost logic. How do I monitor my MIPS score and max out my points? So review 2022 quality benchmark file. Thank goodness we're going to get that. And we're going to have benchmarks so that we'll be able to look at them and see which ones are worth max points. It's going to be really important with your quality that you're choosing measures that have high benchmarks so that you can get the max points on that. Run your quality reports monthly. and confirm your MIPS score. Run your reports if you are using a direct EHR as your reporting method. If you're using a registry, you want to make sure you're out at the registry, checking your measures, make sure they are pulling over correctly, just staying on top of it month to month. That way, if you see some type of gap, you can take care of it immediately and you're not waiting to the end of the year. Run your PI reports monthly, target the best 90 days. That's important also. You want to make sure excuse me, that you are targeting your best 90 days for reporting. Address gaps quickly. They grow faster than you think. Again, you don't want something going on at the beginning of the year and you don't find it until October. Train staff and follow up to ensure they are being consistent, and continuously check in with the our vendor for updates on regulatory items, which the compliance corner is very important with that. You can also find training materials for NextTech software out on the community portal. You have the Compliance University, and you can see it for each software that we have. So make sure and use this for any type of training that you may need. How do I know what I scored in previous? Go ahead, Heather.
You want me to go? Okay. I heard you needing to
right.
Take a little sip of water. All right, number 5. So how do I know what I scored in previous performance years? And again, this is always just drilling into previous year feedback, particularly in that cost category. You can get this at your QPP account login if you have not established one. If you utilize the registries and just allow them to submit for you, I would just highly recommend getting this QPP account set up, get attached to your practice. There is feedback there, and it'll give you the details to drill into and really help you with your strategies moving forward in the 2022 year, where every point is going to count. I don't know if Christy and I can say it enough times tonight, but with losing bonus points and benchmarking being where we know it is, where you almost have to be perfect to get that 9 or 10 points out of a measure. Without a bonus point, if you aren't at perfect, it's going to be extremely difficult to get those max 60 points that we've been seeing in the quality category when we had our lovely bonus points. So again, education, make sure you're getting in there and seeing those previous years. Number 6 has always been, should I apply for the hardship application for PI? Obviously in 2022, they're making it an automatic, which is great, okay? For those of us that are able to max out quality, what is really the difference? You know, I mean, you could reweight it, it goes to it. Now, when we get to no more bonus points, when we get to no more 3-point floors, getting 60 points in quality is going to be pretty difficult. PI is not as hard to gain the 25 points. It's 90 days of reporting. You can be on it, you can knock it out, and then you get all points versus taking these points and reweighting them to a quality category that in 2022 is going to be very, very tough to keep and, max out our points. So even though they're doing an automatic extreme hardship or automatic small practice application for 2022, I would really leave it out there as an option so that you can assume all of those 25 points. Even if you're down a few points in the quality category, why do you want to reweight it when you can get all 25 in the PI category? So obviously, if you don't have certified technology or internet connection or outside uncontrollable circumstances, totally makes sense as to why you could apply. But I just don't want you to think it needs to be an automatic walk away because you might need all these 25 points with the way things are moving into 2022. So the next thing a lot of people always ask, are there hardships for COVID in 2022? As of now, they have not released anything for 2022, but 2021 has had options for you to apply for an automatic or a reweight of your categories. They did extend that application out until November, and kind of hot off the press today is they've actually extended an automatic reweight for all of 2021 for those that don't report. Now, it's based under individual eligibility. So if you report as a group, the automatic reweight would not apply. So if you're attached to a tax ID as an individual, your group reporting is optional. So if you don't report as a group, you would not be penalized because it's considered an option. But individually, if you don't report, the auto reweight would apply. But if you're attached to some tax ID that ends up reporting, you would be receiving the score of that group. So sometimes providers are attached to multiple groups. So checking your QPP eligibility, what tax IDs are you associated with? If you are going to take an auto reweight, if any data gets in under a group attestation, you would be receiving that MIPS score. So it did come out today that they were going to do the auto reweight, but it is not like it has been previous years because it only applies to the individual eligibility under QPP MIPS. So I, again, haven't even dived into it yet because it literally just came out today. So don't think it's just, okay, we don't need to do anything now. We're free. There's no penalties, but it has a different layer in it than it did in the past. And again, just released today. So just keep that out there in regards to COVID. They still are feeling that practices have been still, hit this year with the implications of it and are offering these hardships. Lastly, is it too late to ask for help? Obviously, we're at the beginning of November. We're in the last 90 days, but we do offer now subscription-based services. The good news about that is we'll jump in at any time, begin where we're at. We know right now at the end of the year, we're closing up on 2021. We're kicking off 2022. So, getting help at any time to me is better than no help. So there are options. We have health checks. We have our attestation through our subscription services, which is our CAS monitor and MIPS. But yeah, you can still get help. There's still time to do it. Now, this year, 60 points, avoid that penalty, or again, they threw out an option today. You might be able to consider it. So recapping on the strategy, if we can't reiterate it enough, 2022 is just, it's bringing it to the real. We've kind of been able to be, let's say, comfortable with some bonus points that allow us to keep our scores at that 100 mark. I know Christy and I both feel this year getting 100 is going to be extremely difficult. Even if you max your scores and get a 5 in cost, you're not getting 100 points. So what can you do about it is you can start monitoring your MIPS every month starting January 1st. Benchmarking should hopefully come out, I'm hoping, as in early January, so we can easily identify what measures are max points. I would put 10 in your pocket that can get 10 points because you're going to need some wiggle. And I would look at those workflows and I would start running reports as quickly as you can, because if we are looking at, again, 99% to get 10 points, there's not a lot of room to have some of those not getting into your numerators. So it's going to be imperative you jump on it as soon as you can in the beginning of the new year. Also, we lost the points there, but we also got a threshold increase to 75 points to avoid a penalty. So that's almost 30 points in a swing. So 60 points gets it this year at 75 next year. Even more important as to why get started ASAP, look at it monthly, and address it as soon as you can so that you're getting those max points. Understand that cost logic. The data is out there. It's kind of hidden. I've given you links today to that code list. I've given you, go to your QPP, dig into previous year data if you can get it, but at least understand the logic of it so that you have an idea of what is going to be accounted as a cost to Medicare. And is there any way to adjust the way you're coding, the way you're providing services to limit, again, those costs to Medicare? Same thing there, going to the QPP website. The data is there. Go get it. And ask for help. We're here to help. It's never too late in my eyes because it's a revolving door. So anything is better than nothing. And next year it's going to be a fun one. So hopefully that gives
Yep.
you kind of like a good overview of what was finalized, what we're going to be looking into in that next 2022 year. I don't see a questions in our.
So I do have a few questions, Heather,
cool.
that I was able to get, and so I'm going to give you a few of them, and then we can go over a few of them. If you do have questions, make sure you're putting them in. I did get through a few questions that I did see, and I haven't been able to see more since, so I don't know if I'm missing them. Yeah, so use the chat box.
If you use the chat box, just make sure you're sending it to the organizers and panelists, and then I'll be able to read it here.
Right. So here's what I have, Heather. I have someone asking, as the program evolves, should practices look at a dedicated MIPS/compliance officer for their practice?
I think it's inevitable. You have to. I mean, it's a 9% penalty. You know, I mean, I think it's a decision to work with a third party, bring it in house.
Correct.
But I believe having a dedicated person managing it and looking at it and having responsibility to it is going to be imperative with the level of points we need and the attention to the detail. It's
that is going to need, right? Yeah. And that, with that, I'm going to add to that. So when you say dedicated, you can bring that in-house if you choose, or you can outsource a MIPS consultant like Heather and I to do it with you. We do have those programs where we are doing it month to month. We're helping with the strategy. It's practically like we're there with you doing it. So so I would check into that first. It may be a little bit cheaper on the practice than bringing an actual full-time employee in to do it 40 hours a week, but I would definitely look into
numbers of what when you run the numbers of what 9% is to an average size ophthalmology, derm, plastics, orthopedic practice, it's a big chunk of money. So if you don't want to lose 9% of your Medicare Part B spending, look at your investment. What is it worth to your practice? Do you have and want someone in-house? Do you want to be able to, work and partner with somebody? So to me, it's just, the impact is coming. We've gotten, due to COVID, some leniency with them not imposing the penalties. So, it's a game of chance somewhat, but again, if you want to put yourself on the positive side and invest in it, I promise you'll get into the exceptional bonus bucket, get over 89 points, and actually make some money. So that's the way I look at it.
So exactly. So let me get this question, because I do like this question that just came up. This one is, I do this for our practice, but I do a lot of other things as well. I like the idea of someone helping me since I manage operations as a whole. Exactly. I wanted to get to this question, so I'm glad that you actually put it in there. Most of the people that we speak to, MIPS is not their, it's your same exact words. It is not this is not what they do all day, every day. They are running operations. They are running a practice. So what happens is, when they're responsible for it and they don't have any help, they are waiting until October, November. It's kind of pushed to the back burner. And then when you get to the end, you're going, okay, I need to run my reports. I did this. I need to do that. Well, it worked in 2019, 2020, 2021. It is not going to be the way to go for 2022. So 100%. That may be what you do in the practice, but then you have all these other responsibilities, and this kind of gets pushed to the back. And that is a lot of what Heather and I do. We have many, many clients like that. So I wanted to make sure I hit on that. The other thing is, Heather, could you please review the public health measure, the reporting with the 5-point bonus? So the registry, where you have to do the registry, clinical data, or the immunization registry.
Sure. So what they did in the final rule is they require now that you report immunizations and electronic case reporting. In most states, connecting to the maybe a cancer case registry, I know that there's always been interface connection issues, but there has to be an attempt to get there. Immunizations, most of our specialists at least, are not administering immunizations, so you can apply for the exclusions, but they are offering a 5 bonus point for attesting to one of the other public health options, which would include the clinical health registries, which would be your IRIS, your data derm, those type of things. So this is
right.
The changes. Last year we had 5. We could pick 2 out of the 5. This year 2 are required, meaning you would have to apply for exclusions, but then you can then add one of the others for additional bonus.
Right. And so I know for immunization registry, exclusion is we don't give immunizations within
right.
you don't administer. So just think about that. If you have the exclusion that you can take, then okay.
And in the case reporting one, I would do a little bit of research on your state if they have a cancer-based registry, particularly for the melanomas and that, and you might have to just have some data validation that the interface is not open to, with
or open.
Yeah, you've kind of got to prove that you made the attempt. It's not just an automatic exclusion like immunizations where you don't perform them.
Right.
So I would definitely dig a little deeper into now that case reporting is required. And if your state has an option for you to connect, you would need to make the attempt to do that and have documentation of it. So another one to kind of keep on the radar, we'll have more information on as we also look more into it, but it's most of them do not interface, but that might not be across every state. So I do believe some states have an open case reporting. So.
Yep. So for cost, the CMS just select 10 random cases or the first 10 cases? How do they pick the cases that they look up? It's once you've hit 10 cases, now you're
it's based
triggered
off of
into the
cost
cost
lists. So the trigger ones,
so
I bill a cataract surgery. It doesn't have any chronic, ocular conditions connected to it. I'm an eligible episode. If I get 10 of those,
so this,
I'm scored.
Yep. And they're not just gonna, it's once you're 10, you're there.
Yeah, exactly.
Yep.
I have practices that end up with 280 eligible episodes. I have practices that have 20. Both are in the measure based off of how many episodes actually qualified. But 10 gets you in the measure.
And I've had help with FigMD in the past. Will Verona take over this year in 2022? I knew you would love this one, Heather.
It is on the, yes. So FigMD will be completing the attestation 2021 year. So through March 31st, Fig will be completing. We'll be using the MIPS dashboard there to submit your attestations with the IRIS registry. And then Verona is set to begin their dashboard in early April and then complete the 2022 year. I'll give you my professional guidance on this is I would use whatever you have in-house to manage your quality. If you have the quality direct EMR measures that are in our platforms or in your platform that you currently use, make sure they work, make sure you have numerator denominators, because it could be definitely 3 months before you see data at the registry. We have a brand new dashboard with Verona. I have every belief that it's going to be a smooth transition. But as with anything new, if we have integration issues, it could be another 3 months, and now you're 6 months into a year that you need to pretty much be perfect. And, I would not set yourself out for failure. I would spend the next 2 months making sure you know how to meet electronic quality measures that are in your platforms and to be able to have them available should you need to. Just some hindsight.
Right. 100%. And I do want to hit this one, Heather, because I think this one's important. So they're asking, was the AMD measure removed? They're a little confused on that, number one. But two, they're saying the fall risk assessment was on the proposed, which we didn't really separate this out. We separated it out on our proposed webinar, but it's a different, there's a fall risk assessment, measure 318, and then there was falls, a different one. So I wanted to hit that just a little bit.
Yep, so the AMD measure was proposed for removal, and it was only removed if you submit it in your claims. And I don't think many people anymore are doing claims-based submission for the quality category. So that's the only part of the AMD measure. So if you map to IRIS to report AMD, you will still be able to report the measure via a registry. If you report AMD through your Medicare Part B claims with G codes, you will not be able to report it there. That's the difference in the AMD and it not being technically removed completely. Just one submission method was removed from how it can be reported. And then like Christy said, the fall risk assessment that you see on the removal list is not the same fall risk screening that is in the platform.
All right, and then this one I can take is, we utilize the TB measure and have been very successful with that one. Can you recommend other measures for us? So TB measure, yes. Lots of clients are very successful with that one. It was a 10-point measure. There is some other measures that you could use. I don't know if you're using referral loop measure 374. That could be something that you could use. If you're using, depending on your submission type, if you're using a registry, Falls 318 that we were just speaking of is not on the registry, but it is a measure within the software. So if you are using the registry, you could do a dual submission and do the 318 within the software. It's a 10-point measure and a high priority. So that's a couple of things that you could do if you were already using the measures within the software. 374 in the software along with measure 318, both of them a 10-point measure at this time, unless something changes when the benchmark comes out for 2022.
Yeah, that's what I was going to add. When we get the benchmark file, maybe like our flu, tobacco, high-risk meds of elderly, which did not have benchmarking, if they get benchmarking, then that changes some things with what's available, within the platforms. But it puts a little wrench in the game.
Correct. So we only have, from what I see, we have like 3 more questions. So I want to try to hit these because we're right at time. One is, will we be doing webinars on how to make sure we are meeting the measures appropriately in MDI when charting?
We are working on, for our CAS accounts, we will be releasing the 2022 template, workflows out on the compliance corner. For our CAS accounts, we do have a virtual library where we will have online videos and we will be hosting webinars, but that is part of our consulting services outside of what is available at the community portal, which would be workflows and how to meet them. So that data will be available, but we do have a separate layer for those that join us in consulting.
Yep. And then I just want to go back to this real quick because someone, from the question that I answered a minute ago about replacing the TB, you said you're using measure 374. How would you incorporate falls into a derm practice? Many, many, many derms practices are using falls. It's a pretty simple measure right now, so I would look into it, read it, but I will tell you almost every single derm practice that I work with, they're using falls, and it's working very well within their practice. So look at the measure, read the measure, and it should be a measure that you would be able to use with a derm practice because many of them are using it. The other thing is,
there's no formal assessment.
Yeah, it's a screening. Exactly. And then how can we contact you all to possibly hire for MIPS consulting?
So the best way to contact your CSM at NextTech, they will create an opportunity, or your ISM, or I don't know if we put our contact information in here, but you can reach out to any of us and we will get you an opportunity open so you can see how to get started doing that.
All right, everyone. That is the end of our Q&A. I hope that the webinar was very helpful for you. And reach out to your CSMs if you would like more information on MIPS consulting, and get prepared for 2022.
Thanks, guys. Cheers.